Hey guys, it's Taylor Busker, and the topic that I am doing my presentation on is acquired apraxia of speech. So, acquired apraxia of speech is an impaired volitional production of articulation and prosody, a disorder of expressive communication as a result of brain damage affecting the normal realization of speech sound sequences, and prosodic features representing speech. It represents an inability to program and sequence articulatory requirements, and it is linked to cortical and/or subcortical damage in the language-dominant hemisphere. But researchers are still not completely positive about the specific brain regions that are involved in apraxia of speech. So there are four clinical characteristics, like a slow rate of speech, speech sound errors, consistent in type, location-specific errors, and disturbed prosody. Some facts about it. Along with apraxia, there is no muscle weakness, paralytic condition, or discoordination that goes along with it. The speech process of articulation is primarily affected. Speech errors based on disruption of the central nervous system's programming of oral movements. And then the articulatory errors are inconsistent. So here are 13 articulatory and phonological characteristics. The first one is, these are characteristics of the speech that have been noted. So the first one is effortful trial and error groping of articulatory movements and attempts at self-correction. This could result in equalization of syllabic stress patterns, slow rate of speech, and other prosodic alterations. Prosodic disturbances, difficulty initiating utterances, articulatory inconsistency on repeated production of the same utterance. However, there are islands of clear, well-articulated speech, and then they will have another problem with a word and then have a problem with it again. The next one is predominance of sound substitution errors. Additions and prolongations also occur, distortions and omissions are less frequent. Possible occurrence of sound or syllable transpositions. Occasional articulatory errors are complications rather than simplifications, which means that a consonant cluster could be substituted for a single consonant. Errors typically related to one another phonetically. Substitutions, for example, could be related in place or manner of articulation to the intended sound. Next, more errors on consonants that require more precise articulatory adjustments, so like fricatives and affricates. There is an increased number of errors in articulatory struggle as words increase in length. Speech comprehension and word recognition abilities often far better than speech production abilities. So they understand and recognize, but they can't produce. The client's recognition of their errors, this means that they understand that they're messing up, they know that they are, they just can't do anything about it. And this could cause numerous retrials or self-correction attempts. And then the last one is, under otherwise comparable conditions, more sound production errors are in stressed than unstressed syllables. So this is the diagnostic section, and the book talked about how you would go about diagnosing apraxia, and it listed off a bunch of assessments, but those ones were specifically for adults. So I wanted to just talk about the process as in general, because we talk a lot about how it would work if you're working with children. So you would give the aphasia test. You would check for intelligence, cognitive, and memory tests as needed. You do the apraxia battery, a speech and motor mechanism examination, you'd give an articulation test, and then you would take a spontaneous speech sample, and all these things you would need to do to diagnose with aphasia. And then the book also talked about some questions. It says both the articulation test and spontaneous speech sample should answer the following questions. Does the client have difficulty initiating utterances? Are there islands of well-articulated speech? Which sound errors occur? Do sound errors have a pattern? And then which prosodic aberrations occur? So those are some things that you'd be looking for when giving some of these tests. So next, therapeutics. These are some things to remember when giving therapy for apraxia. Articulatory accuracy is better for meaningful than for non-meaningful utterances, which means that you should avoid nonsense syllables. All treatment stimuli should be meaningful. Errors increase as words increase in length. Determine the level at which the client demonstrates accurate production most of the time, and then build on that level. For example, if the assessment reveals that the client can do CV, CVC, VC, syllable structures easily, then you're going to start with this level of functioning, and then you're slowly going to build to more complex syllable shapes, so like CV, CV. But you want to start out with what they can already do, and then move up. And work on easier two-syllable words when you move up. Errors increase as the distance between successive points of articulation increases. So evaluate your word material. Organize it so that this factor is taken into consideration. If you're working on consonant clusters, ST should be easier than SK. If you're structuring words, toilet should be easier than shopping. And then number 4, errors increase on consonants that require more precise articulatory adjustments. So fricatives, affricates, consonant clusters, those are very difficult for some clients who have apraxia. So you're going to start with other sound classes until more volitional control is approved. So then I found in the book there are 4 categories of treatment, and it didn't really explain these 4 at all, except for it explains the articulatory kinematic. So I'll talk about that one a little bit. But the 4 categories of treatment, they came to this conclusion after doing an extensive review of apraxia speech treatment literature. These are the main categories of treatment. So there's articulatory kinematic, rate and or rhythm, alternative and augmentative communication, and then intersystematic facilitation and reorganization. I do know enough about the AAC because that is usually for more nonverbal patients, and that's using a machine to either type in the words, touch things on a touch screen that it'll then speak for you, or then even in severe cases there's an eye gaze machine. But a lot of times they'll have like a word board or something like that where they can touch what they're trying to say if they can't physically say it. But then the articulatory kinematic, the book has 3 different main areas, I guess, that this therapy category works with. And it starts with motoric practice. I guess stimulation is provided by the clinician, and then the client responds with verbal production. So it's a modeling repetition structure. There's use of articulatory placement cues. So this method is used to communicate specific information about sound production. So placement cues are given for sounds produced in air, and then they've taken the form of drawings, videotaped models, verbal instructions, visual modeling, it's just cueing. And then the third thing about this category is use of prompts for restructuring oral, muscular, phonetic targets. I guess this technique has also been utilized with childhood apraxia, but children with cerebral palsy and dysarthria. So I guess that one is an effective technique as well. So then there's my video. I'm not sure if it'll play in here, so I'm not even gonna try. I'm just gonna send you the. Oh wait, maybe it will. Maybe I'll try it. Okay, so that is an example of apraxia. Um, like it said in the book, a lot of times they will have islands of clear speech. She didn't seem to have any, so she probably had a more severe case of it. But usually there will be words that they can say perfectly fine and fluent, and then they will struggle on other words again. But that is not the case with her. So that is my presentation. That is apraxia of speech, and I hope you enjoyed.